Hello everyone, I am Dr. Neha Patel, consultant radiation oncologist from Surat, India. I welcome you all to this breast cancer conference. And today we have all gathered here to this beautiful World Breast Cancer Conference. I'm really privileged and grateful to all the organizers for providing me with this opportunity, and today I'll be speaking on male breast cancer. We are reaching into the end of this Breast Cancer Awareness Month, but nonetheless, it cannot be completed without his breast cancer awareness. So, male also get breast cancer, and so we should discuss about it because men can get it too. So, here I am sharing you my screen. Uh, and I'll be presenting on male breast cancer. So first of all, we'll be looking into the anatomy of the male and female breast cancers. So everybody at the time of birth have a breast, and in females during puberty under the influence of estrogen and progesterone, the breast develop into a fatty tissue which composed of ducts and the lobules. Whereas in males, because of the effect of testosterone, these ductules and lobules are not formed, and the breast in the male will directly lie on the pectoralis major muscles. Now, what are the major differences between the male and female breast cancer? Male and female breast is that females will have a nipple areola complex which have ducts which secrete milk which are formed in the breast lobules, whereas under the influence of testosterone, all these ducts become atrophic and they are lying in the subareolar region near the nipple. We don't have lobules in case of males. And to support the fatty tissue in females, we have Cooper ligaments, whereas it is absent in males. So the breast tissue is lying over the pectoralis major and it extends from second to sixth rib. Coming to the incidence of male breast cancer, it is around less than 1% of all the male cancers. A male will have a lifetime risk of getting breast cancer, according to the American Cancer Society, is around 1 in 833 men. Now, the mean age group of diagnosis is in the older age, which is around 60 to 64 years of age. Nonetheless, young age group can also have breast cancer. Around 20% of males have first degree relative with breast cancer history. Also, the Jewish men have higher incidence of breast cancer. It is because of more incidence of BRCA2 mutation in Jewish men. Black males, that is Chinese and African men, will have higher incidence of around 6% as compared to 1% in general population. This is because these men will have higher incidence of endemic hepatic pathologies, which increases the estrogen level inside their body. The male breast cancer are 90% hormonally driven and they are ER positive. Coming to the risk factors. Now, what are the risk factors which exposes a man to have a breast cancer? So, as in female, male also have age predilections. It is directly proportional to the age. As we grow older, both male and female will have a tendency to get a breast cancer. The second risk factor is the positive family history. A man with having a positive family history will have a relative risk of around 2.5% more uh, incidence of having them with breast cancers. Also, the genetic factors affect the incidence of breast cancer. A male having BRCA2 mutation will have more chances of getting breast cancer as compared to BRCA1 mutation. And their incidence of having breast cancer would be in the early age group. The next risk factor is the Jewish heritage, as I have already discussed, that Jewish people have more chances of BRCA2 mutation. Other genetic factors are like Klinefelter syndrome. In these also the male are diagnosed in the younger age group. Mutation of AR gene, CYP17, P10 tumor suppression gene, and CHEK2 mutation. These are the factors which increases the risk of having breast cancers in males. Next is anything which affect the hormonal balance inside the male will increases their chance of having the breast cancer. So the external use of hormones, obesity, which increases the estrogen level, orchitis and epididymitis, which also increases the estrogen and decreases the testosterone, and a patient are having prostate cancer, which is treated by estrogen. All these hormonal imbalances in the body will expose a man to breast cancer. Then, if a patient is having a radiation prior in the younger age group, maybe for lymphoma or any other cancer uh, uh, in their body, they will have higher chances of getting the breast cancer. Males who have high BMI and do less amount of physical activity is also a risk factor for getting a breast cancer. Coming to something new which is not seen in females is the having the history of liver diseases. Any liver pathology because of alcohol, if a patient is having cirrhosis or any other liver pathology, it causes the increase in the estrogen level and decrease in the androgen levels in the men, and it exposes males to get a breast cancer. Also, the testicular pathologies like undescended testes, orchidectomy, or orchitis decreases the testosterone level in the male body and hence exposes them or have the risk factor of getting more of male breast cancers. Also, there has been seen that there is increased simultaneous association of breast and prostate cancer in males. First of all, because of BRCA2 positivity, and second is the aromatase inhibitors used for the breast cancer patient. It increases the testosterone level, which increases the growth of the prostatic cancer clones. Now, what are the symptoms by which we can diagnose that a man can have a breast cancer? So, a man can have a swelling or lump in the breast, the most common site being retroareolar. There can be lump in the underarm region. There can be pain, ulceration, redness, and dimpling of the skin. There can be tender or inverted nipple with a nipple discharge. Now, what are the diagnostic criteria? What to do next if a male see these kind of symptoms? They should undergo a mammogram, an ultrasound. Mammogram is preferred more as compared to ultrasound. But if the male is of younger age group, that is less than 25 years of age, then they should be offered ultrasound. If required, we can go for MRI. And if we have a suspicious lesion on mammogram and ultrasound, we can go for biopsy and PET-CT scan for proper staging of the tumor. Now, who should be tested? Any symptomatic patient should be tested with all these tests. A male with having family history of male breast cancer should be tested, and a male having BRCA2 gene positivity, they should be offered mammogram and ultrasound. Now, what are the differential diagnoses of these swellings in the male breast? It can be the most and the most common is the gynecomastia. It can be other benign lesions also, like lipoma, fat necrosis, hematoma, abscess. It can be intraductal papilloma cyst. It can be ductasia or a metastatic tumor into the breast. Now, generally, these all are missed and diagnosed in the later stage because of lack of awareness, lack of screening, a social stigma, and often these are misdiagnosed. Now, we'll be discussing more about the gynecomastia as it is most common differential diagnosis in case of breast cancer. Now, these are the two films of mammogram. On the left, we have a mammogram of a breast cancer patient, and on the right, we have a mammogram of gynecomastia patient. Now, in the left, we can see that we have a small irregular retroareolar mass, which is located eccentrically near the nipple. These masses don't have any microcalcifications. Whereas in gynecomastia, we have a flame-shaped subareolar density which is radiating outside the nipple. This is the dendritic type of gynecomastia. Now, the most common differential diagnosis of breast swelling in male is, of course, the gynecomastia. But gynecomastia is not a risk factor for having a male breast cancer. But gynecomastia can have a concurrent breast cancer with them, so they should be offered mammogram after the age of 50. Now, the basic differences between the gynecomastia and male breast cancer. Now, the gynecomastia have bimodal age distribution. It can be peripubertal or can be diagnosed in the old age, whereas male breast cancer are mainly seen after the age of 60 years. Now, gynecomastia are generally swellings which are soft, mobile, and tender, and they are located centrally in the subareolar region. Whereas the male breast cancer can be soft or hard, it can be mobile or fixed, or it is mostly non-tender, but sometimes in the advanced stage it can be a tender swelling. They are located mainly in the eccentrically in the subareolar region. Now, the gynecomastia tend to be bilateral in nature. They affect both the breast, whereas the male breast cancer are mainly in the unilateral region. Now, comparing the mammography findings of both of them is mammogram of gynecomastia will have a fibrotic subareolar density with extension into the fat. Whereas in male breast cancer, it will be radiodense irregular mass with spiculated margin and chances of having calcification are very less. Now, who should get a genetic testing? So all the male breast cancer patients should have BRCA2 gene test. And the first degree relative having a breast cancer in early age or a patient having bilateral breast cancer or history of ovarian cancer in the family and who is the first degree relative of the male should have BRCA gene testing. Now the BRCA2 positivity in males will increases uh, uh, in female it increases the chances of getting breast cancer from 13% to 70%, which is very huge. But in males, it only increases the risk of getting male breast cancer from 0.1% to 7%. Also, it is seen that BRCA2 positive mutation are more common in male breast cancer. Now, BRCA positivity increases the men risk of getting prostate and pancreatic cancers also, and their chances of getting prostatic cancer is more as compared to the male breast cancers. Now, as of now, we don't offer any prophylactic mastectomy for the BRCA positive patient in cases of male. Now, what are the screening recommendations for BRCA positive patient? The BRCA positive patient should have a genetic counseling and they should be aware of doing breast self examination. They should start at the age of 25 years and they should undergo an annual clinical examination after the age of 35 years, and it should be followed every 12 months. BRCA2 positive men should undergo annual mammogram screening uh, at around 10 years before the earliest known male breast cancer in the family, and also in the male with having gynecomastia starting at the age of 50. Now, BRCA positive men who are less than 25 years of age should be offered ultrasound, whereas those males who are more than 25 years of age should be offered mammogram according to the American Cancer Society guidelines. Now, looking into the pathology of breast cancers, now males will have more of infiltrating or invasive ductal carcinoma, which is around 93.7% and is the most common type of breast cancer seen in the men. Whereas the invasive lobular carcinoma incidence is around only 1.5%, which is very rare. It is mainly because the male breasts don't have lobules, and these lobules are lacking under the influence of testosterone and lack of estrogen. Other breast cancers diagnosed in men are ductal carcinoma in situ, inflammatory breast cancer, papillary mucinous cancers, lymphomas, Paget disease of the nipple, liposarcomas, and metastasis. Now, male breast cancers shows a higher uh, estrogen and progesterone receptor expression as compared to women. Now, 60 to 70% of female breast cancer are ER/PR positive, whereas in males it is around 90 to 80%. Looking into the HER2/neu expression, it is around 15% in case of men, which is lower in men as compared to females. 9% of the male breast cancers are triple negative in nature. Now, looking into the staging, prognosis, and the treatment of male breast cancer. Now, the incidence of male breast cancer is very less. As we can see, it is around less than 1%. So, the staging and treatment is extrapolated from the management of the female breast cancer, because as such we don't have much data or any randomized trial looking into particularly into the male breast cancer. So the staging is same as of female breast cancers. Coming to the treatment, generally males are offered MRM as a surgical treatment of choice, because lumpectomy is mostly not feasible, but for cosmetic reasons, males can also be offered lumpectomy or breast reconstruction as per their choice. Sentinel lymph node biopsy is also offered and is validated in case of male breast cancers. Coming to chemotherapy, it should be advised to patients who have tumor more than 1 centimeter, or the lymph node positivity in axilla, or the hormone receptor negative tumors. Coming to the difference of response to the chemotherapy in case of male, we can see that males, if we offer them neoadjuvant chemotherapy in case of male breast cancer, it is seen that as compared to female breast cancer, male will have lower proportion of pathologically CR after receiving the neoadjuvant chemotherapy. So pathologically, CR rate is a prognostic factor for both male and female breast cancer. And this study by Leone et al. Shows that male breast cancers are intrinsically more resistant to neoadjuvant chemotherapy and they are more aggressive as compared to female breast cancers. Uh, then coming to the radiation should be offered to males who have more than 5 centimeters of tumor, who have margin positivity or lymph node positivity. And hormonal therapy should be given as per given in the female breast cancers like ERPR, as I have already told that male breast cancer tend to have more ERPR positivity, and so the tamoxifen should be offered to males after the primary treatment. They can be offered targeted therapy or immunotherapy as per the indication. Pembrolizumab should be offered for triple negative tumors, and if the patient is diagnosed as metastatic disease at the time of presentation, we know that metastatic disease are not curable, but they are controllable. We can give a good quality of life to them. So, if the metastatic disease is ER positive, HER2 negative, they should be offered tamoxifen and CDK4 inhibitors like palbociclib. If it is ER positive and HER2 positive, they should be given a hormonal treatment along with trastuzumab and pertuzumab and new generation drugs like Enhertu and tucatinib, which is a tyrosine kinase inhibitor. Now, what are the differences? The main differences in male and female breast cancers. So far we have seen that incidence of breast cancer in males is lesser as compared to females. And looking into the pathological differentiation, the invasive lobular carcinomas and in situ carcinomas incidence is lesser in males as compared to females because of lack of lobules. Coming to BRCA2 positivity, the BRCA2 positivity in women will raise their risk of having breast cancer from 13 to 70%. But in males, it raises the risk from 0.1 to 7% only. Also, the BRCA2 positive men have higher risk of developing prostate cancer as compared to breast cancer or other cancers. Now, coming to the location of the tumor, it is mainly located in the subareolar region, which have rudimentary duct present near the nipple. Whereas in females, it is seen mainly towards the upper outer quadrant, which is the denser area of the female breast. The malignant calcification are lesser seen in males in mammogram as compared to females. These are all the differentiating factors. Now, coming into the immunohistopathological analysis of these male and female breast cancer, the study by Muir et al. Has found that males will have more of higher grade tumors, grade 3 tumors, around 85%, as compared to females, which are around 50% of grade 3 tumors. Also, male breast cancer will have more ER/PR positivity as compared to females. Though male breast cancers are of higher grade as compared to females, they don't overexpress P53 and HER2 receptors. These are the main immunohistological differences, and all these differences warrant us to look into the different treatment strategies which can be offered to this subgroup of patient which are behaving uniquely and differently from the female breast cancers. So lastly, we'll look into the prognosis of the male breast cancers. Though it is very rare in males, but it has been seen that 20 to 40% of males have higher risk of death and they have worse prognosis as compared to females, despite having hormonally positive tumors. This can be mainly because of later age of presentation, because of undertreatment, some kind of social stigma, because of advanced stage of diagnosis, or there can be delay of treatment and lack of awareness among the male that they can also have breast cancer and men can get it too. So the overall 5-year survival rate is around 40 to 65% in cases of male, and it is the conclusion is males have more aggressive disease as compared to female, and they have a worse prognosis. And so these subgroup of male breast cancers, they should be treated aggressively, and again we should look into the different treatment strategies which can be offered to this male, because till now we are extrapolating all the data from the female breast cancer, and these male breast cancers should be studied differently, and more and more randomized trials should be offered and should be done on this. Thank you. I'm Dr. Neha Patel, consultant radiation oncologist from Surat, India. I thank you for patient listening. Thank you.